a lot behind the scenes, and it's very important to know what's happening between psychology, behavioral medicine, etc. And we digest it and give it to the patient. So I'm going to quickly talk about the past, present, and the future. So starting with the past, we're not going to dwell on the past because, as you can see, the past is to learn from, not to live in. That's really important because if you have people with depression, a lot of times they're living in the past and we want to move them forward. But let's learn from the past of neurosciences. So this is one slide to review a whole century. This is the 20th century. I hope I'm not blocking you. Can you see in the back? Okay, good. So, so if you look at the first century, it was black bile. They thought people who had mental illness had abnormal color bile. We've come a long ways. So I'm going to take you to the 20th century. There really wasn't much at the beginning of the 20th. There was Freud and psychoanalysis. Then in the 30s and 40s, there was shock therapy and insulin shock and electric shock. And then antidepressants entered in the 1950s with some of the older ones, Elevol, Tofranil, MAOIs. There was a revolution in medication in the 80s and 90s. Those of you who've been around for a while remember the promise of Prozac. When Prozac came on the market, everybody said this is a miracle pill. And we've gone way beyond that now. And now we have, in the 21st century, transcranial magnetic stimulation and deep stimulation, which I'm going to talk about. So there was a big boost in the late 80s, mid 80s to the late 1990s. And this I'm going to go through very quickly because this is technical and after lunch, I don't want you to fall asleep on me. So this is discovering, I love showing the Golden Gate Bridge, but neurotransmitters are electrical messengers in the synapses of the brain, billions of synapses. We discovered many of them. So serotonin, those of you who hear SSRIs, you know, Prozac and company, selective serotonin reuptake inhibitor, this is the brain. So look at all the pathways. Not all of them are good. Sometimes you hit the wrong pathway, you can have side effects. And then there is norepinephrine, which is also anxiety and depression, headquarters in the locus coeruleus. Nucleus accumbens is important because that's the center for desire and drive. A lot of people with mental conditions as well as special needs might have lack of motivation, lack of drive, so due to an imbalance in this area of the brain. Amygdala is the emotional memory center of the brain. If someone had a trauma, the amygdala is where the memories are stored. And then we have dopamine. Dopamine, all of you know. Dopamine, really, if you have a kid or an adult with ADHD, basically, it's the prefrontal area of the brain. There are several functions related to dopamine. So if you look at the prefrontal area, and if you have someone with attentional issues, that's a dopamine norepinephrine imbalance in that area of the brain. If you're a neurologist, I'm trained, by the way, in neurology and psychiatry, but if you look at neurology, the nigrostriatal pathway is the path where Parkinson's disease and tremor is. If you look at depression, you look at the mesolimbic pathway. This is the area that's deprived of dopamine, that people feel flat, unmotivated. And so it's important to know, and also addiction is related. Thank you very much. So this is only less than 20 years ago, a professor Metzner at UCLA who tried to say, how can we choose medication? And just tells you how in 20 years we've come a long ways. He was saying if it is a behavioral issue with anxiety, irritability, obsession, agitation, it's probably a serotonin imbalance. If you have lack of motivation, fatigue, apathy, anhedonia, it's probably norepinephrine dopamine imbalance. If you look at that list, I bet you will see some features in your loved ones. So what do? Throw the kitchen sink at them? And that's where we were less than 20 years ago. So, in spite of all the medication research of the 20th century, so this is a question for you. Show of hands. Do we have medications that are well tolerated? Hands? Work often? Yeah, I'm not seeing too many hands. And this is important, produce full recovery. I think you see a lot of the studies with medication show progress, but not full recovery. So let me tell you, being trained in medicine also, if somebody's blood sugar is 400 when they come to me, dropping it to 200 is not good enough. It needs to get under 140. So with behavioral and emotional issues, you want to try to treat them to wellness as much as possible. So this I'm going to go through quickly. Bottom line is adequate treatment of depression is the exception to the rule. Why? So this is the iceberg here. Do you have the right diagnosis, the right medication, the right medical conditions? You're not surprised to see only 18% of everybody on antidepressant across the US is doing perfectly well. That's not high. Maybe 40% are better, but 18% is fully recovered. So the National Institute of Mental Health set a trial. This I want you to research. It's available on the public media domain. The trial is called STAR-D, which stands for Sequence Treatment Alternatives to Relieve Depression. This is the biggest study in the world on depression, sponsored by National Institute of Mental Health. They recruited 4,000 adults who have depression across the US. It was published in the American Journal of Psychiatry in 2003. So everybody has to be on has to have depression. This, I can be an hour telling you about the study, but I am going to spend a minute on that. They wanted to see what algorithms are appropriate. So everybody in level 1 is on serotonin reuptake inhibitors. They choose Celexa here, citalopram, which represents it, and they measured progress by full recovery. Are you surprised in this study? This, by the way, was in psychiatric clinics. The first one I showed you included primary care clinics. So in psychiatric clinics, only 28% or less are fully recovered on an SSRI. So the remaining 72% had an option level 2 to do combination, serotonin, norepinephrine, dopamine, or psychotherapy. Level 3 include an atypical antipsychotic, Abilify, Risperdal, etc. Level 4, multiple augmentation. But look at the decline in further response. And worse, look at the dropout rates in the trials. Because when you throw too many medications, what happens? You're going to have potential side effects, right? So tolerability becomes an issue. At level 4, almost 50% of people stopped because of side effects. I call it the shotgun effect. So this is the environment I was practicing in, and I have a funny story here. In 2000, I had an office in Los Altos at that time, and I've always specialized in difficult to treat depression, anxiety. So then I said, what can we do? So advances in sciences. So this brings us to the past 20 years that I've been in practice. And I like to show you this. This is one of the fathers of medicine, William Osler. He said, the good physician treats the disease. The great physician treats the patient who has the disease. So listen to that. Because a lot of times you go to a provider and say, oh, this medication is going to work for this condition, but they really don't look at the emotional need, the support system, the family support, etc. So I am proud of all of you for being so involved on a beautiful Saturday, being here, because advocates, NAMI, PHP, others are really important part, teaming with the professional and with the community support. I came in early, Trudy invited me, and I loved listening to all the panels so far. I think there's so many resources. So very important to really not look at one aspect, but look at the whole person. I said that because from now on, I'm going to talk about the technical aspect of development. But I apologize because in our practice, we do everything. Counseling, psychotherapy, etc. Not just medication. I subspecialize in medical management with complicated cases. So the research, really, this is exciting. You know, you've seen color scans of the brain. So technology, and being in Silicon Valley, has advanced enough that, remember I mentioned the amygdala. Look at the amygdala. It's on the bottom side of the brain. It's the size of the head of your pen. But it has all of the emotional memories stored. If you have a trauma victim, that area has a lot of memories in there. And if they see a cat in the dark and they have a fear of cats, they're going to have a panic attack. So now we know a lot about the functions of the brain due to their studies. And we also discovered, actually, those of you who saw in the paper yesterday, there was a mouse study at UCSF on panic attacks. You saw that? And actually the area was the hippocampus. Hippocampus has special neurons for anxiety and depression. Chronic depression results in atrophy, as you can see here, which you can't really see. I'm going to show you this. I'm competing with the microphone here. So this is a study done in St. Louis on women who had depression. Am I getting...
I don't think it likes the laser. Yeah.
Oh, okay. There you go. See, what would I do without Rudy? Huh? All right, so I'll try to minimize the laser. Okay, so this is a study that showed people who were treated effectively restored the functionality of the hippocampus. So the great news is emotional and mood disorders are improvable and you can reverse the damage in the brain. Unlike dementia or Alzheimer's or MS, even though there's research in those areas. So this was a big revolution. We discovered brain-derived neurotrophic factor. You can regenerate connectivity in the brain if you know what you're doing, whether it's talk therapy, whether it's medication, whether it's TMS, but don't give up until you get the patient well. And also, it's important to recognize that stress is not a negative effect on the brain itself and the nervous system. It's a negative effect on inflammatory cytokines, which is the immune system, hypothalamus pituitary axis. A simple example, let's say a woman under severe stress, she misses a period. How does that happen? The hypothalamus controls the pituitary, and pituitary controls the adrenal and the thyroid and all that stuff. So very important to recognize that stress is systemic. We hear about stress is dangerous to your health. Believe it, it is dangerous for your health. And I'm not talking about suicide only. I'm talking about heart attacks, strokes, etc. So it's very important. So the good news here is that in animal studies, we can regenerate connectivity if we have the right concoctions. So this is my favorite slide of the deck, because I tell my colleagues in neurology, 1/3 of the brain is wired for mood, anxiety, and behavioral issues. So I want you to look at this area, CG25. Can you see CG25? So that is called the cingulate area 25, or dorsolateral prefrontal cortex. But you don't have to memorize that. I have a nickname, as long as you mention it's Shakir's nickname. I call it Grand Central Station. Grand Central Station for the pathway of anxiety and depression. And it's like a central computer that controls peripherals. Rather than fix the peripherals, you go to the central area and you fix it. That's the crux of what TMS is. That's what I'm going to talk about next. So there's a new field now called neuromodulation, innovative especially, without surgery, without anesthesia, and it's not shock therapy. So very important to emphasize. How did we get there? MRI technology was diagnostic in the 70s and 80s. There's a funny part to that story, so look at the screen and look at our famous Tony Barker, who is a physicist in Sheffield, England. He was doing research in 1985, would you believe it? And this is a handheld magnet. This young lady had depression. Every time he hit the area CG25, she starts laughing. Not other areas of the brain. So that was the first indication in modern medicine that we can apply high-power magnetic resonance imaging field into the brain and alter symptoms and behavior. So there was a good paper in Canada and Germany. Our Food and Drug Administration is very conservative in the US. And I was reviewing the European literature and I said, when are we going to learn about the TMS? And then this happens. So this is the year 2000. The FDA mandated that they study in North America 23 centers to recruit 301 patients with depression to see if TMS works. To my great fortune, one of the 20 in the US was Stanford, where I had finished my training. And to my doubly good fortune, one of my private patients, at that time, she was a Stanford student, 22 years old, and I was treating her for depression for a couple of years. Nothing had worked. She walks into my office one day and says, I want to do TMS. So I knew the investigator. I called him, made sure it's not a gimmicky thing, and make sure it's safe. So long story short, I gave her the green light to be in the study. And to my very pleasant surprise, it was life-changing for her. She went to Stanford for daily treatment, for 6 weeks. And this was the device that was used in that study. And she was a new person. Canada approved it right away. 3 of the sites were Canada. But I got drooling to when the US is going to approve it, and I got a special gift in 2008. This is approved. This is one of the chairs we have. We have now 12 chairs for treatment. This is one of them. This is the original one approved in 2008 in the US. This is an American company called Neurosciences that made this chair. This is the magnet. This is the control panel. I call it the Rolls-Royce of TMS at that time. We now have 2nd and 3rd generation devices. So what is TMS? It's rapid transcranial magnetic stimulation. So you localize the area I mentioned. It's based on physics. You basically depolarize and improve connectivity. And you don't have to throw serotonin or epinephrine, dopamine. I always say diagnosis don't make a difference. We treat regions in the brain. So the region we treat controls executive function, mood, anxiety, libido, sleep, etc. So if they're having depression, that's the area. So the APA, American Psychiatric, really jumped at it, and best practices, guidelines, December 2010, because rather than throw so many medications, they said if you fail 1 to 4 antidepressants, you're a good candidate. Of course, the insurance never makes it that easy. Initially, there was no insurance coverage. Now, many insurances are covering it, but the bar is much higher, 4 to 6 medications. So this is a summary of what I said. So the blue areas are underactive, the red is overactive. So if you look at, this is a very important slide. So look at the areas that regulate mood, and look what's going to happen when the depression sets in. So a lot of the symptoms of depression are related to deprivations of conductivity in those areas of the brain. And when you give them oral medication, it is shotgun effect, you hope. So this is the brain of a depressed person. You swallow the capsule or the tablet. Unfortunately, it goes all over, and we have no control over the side effects and selectivity. So if your loved one is doing good with medication, hooray, great. If they're not, get genetic studies, get them to look at other alternatives. So TMS goes directly to the area I showed you, and without surgery and anesthesia, we stimulate the brain and results in depolarization. And because the brain is heavily connected, look what's going to happen. We reboot production sites and improve connectivity in the brain. So look at the lighting up of the areas. So this is a depressed person's brain without the magnet. This is one of the magnets. You see the areas that light up. But you have to know exactly the area to treat, and that's what we do with localization. So for the sake of time, I'm going to skip through this. So this is the position the patient sits in. Different devices, but it's less than 20-minute treatment. This is the head position with this device. And now it's endorsed by the American Psychiatric, World Federation, Canadian, etc. So let me now show you a video segment, if we can get this to work. And it shows you, so it got really a lot of publicity. Can you make it work? She's the expert, see? If it doesn't, then we can go to Dr. Oz, that's okay. I know that works. If Dr. Shakir doesn't show up. So basically I was on NBC and they should, no worries. I'll show them.
Coming back, give it a second.
Okay.
Okay,
There we go. Wow, all the talents here. Here we go. It's working, Trudy.
I want to make sure you
The audio. The audio will come in a minute. There we go.
No drugs, no side effects, no invasive surgery whatsoever. When medication is no longer enough, some in the Bay Area have found a controversial therapy to treat depression.
No more controversial. This was 2012.
personal matter, depression. It affects more than 18 million Americans. But for many, medications provide little relief and a lot of side effects. NBC's Marianne Favreau shows us how some patients here in the Bay Area are turning to a new magnetic therapy to help repel their depression.
First thing we're going to do is position you.
Walt Stever has battled severe depression for 30 years.
When it's not treated, it's terrible. You go into a deep black hole. You don't want to do anything.
That black hole affected his work, family, even his driving. Antidepressants offer moderate relief with many side effects, including headaches, nausea, and dry mouth. After consulting Dr. Saad Shakir in Los Gatos, Walt opted to try a totally different treatment, transcranial magnetic stimulation, or TMS. A small curved device rests on Walt's head and delivers magnetic stimulation directly to a golf ball-sized section of the brain scientists believe helps regulate undergoing the FDA-approved treatment 5 times a week for 5 weeks. Walt says he's a new man.
It's absolutely astonishing what the treatments have achieved.
Because the treatment is localized to the brain, patients avoid the side effects of medications.
No weight gain, sexual dysfunction, fatigue, lethargy, sleeping too much. That's what's remarkable.
Of the patients Dr. Shakir has treated with TMS, more than half have been able to significantly reduce the number of antidepressants they're taking or get off their meds entirely. And most patients were able to keep their depression at bay for months.
The TMS trials, 90% remission rate in the first 6 months.
TMS is not for everyone. Dr. Shakir still recommends patients try antidepressants first. And it's not a cure for depression. Most patients, including Walt, will have to return for maintenance sessions. But he considers it a small price to pay to shine light on the darkness that once consumed him.
I feel great. I wished I had this 30 years ago.
In Los Gatos, Marianne Favreau, and
So now there are, and keep your questions at the end. I'm going to stay around hopefully for a few minutes. So there are now about 700 centers in the U.S. and the whole world is looking. I do a lot of traveling and teaching and training. So if you look at the yellow, all academic centers of reputation and private practice, Northern California, Silicon Valley has 4 centers, so we're one of the largest actually in the country now. I'm going to skip Dr. Oz, is that okay? Because we don't have enough time. Dr. Oz was really excited. This was in, if you want to look it up, March 15th, 2012.
So this is a magnet, right? The magnet.
Okay, so let's skip this one. So let's skip this one. So this is us, Silicon Valley. This is the red one is what I'm very proud of. We're now International Center of Excellence, so I do a lot of training for people around the world. And we've had some great outcomes. So we shared our outcomes with the American Psychiatric. Let me skip this. Let me just show you that we've had up to 85% success rates in treating depression, which is unheard of with medications alone. I'll show you a segment of this. 2 years after she finished.
It's been a while. So I'm glad that you can talk to me today. So I want to ask you a few questions if I may. It's been a while since you finished the TMS.
Yes.
How long have you been?
About 2.5 years.
2.5 years. So how is that going?
She's a school teacher at San Mateo.
I'm able to do more things than I used to do. I'm not afraid to try new things and take on more challenges. I'm very careful. If a new opportunity arises, my first inclination is to jump on it and do it. But I know I don't want to overload myself.
Okay, I'm going to move on because I don't want to run out of time. So basically, she's doing really well. Before TMS, she'd been on 5 different medications. And now she is 1,000% better on half a dose of one medication. And she continues to be my patient. We check in every 3 months. The second generation device is called BrainsWay. This is being studied in autism spectrum and many other conditions. It's the same philosophy, but deeper coiled. And we were the first to bring it in the West Coast. And now we just celebrated 4 years with the BrainsWay. We've been open, this is our 8th year. This is what it looks like. It's more like a football helmet. It's FDA approved for depression, 20-minute session, safe, and patented by the National Institute of Health. And this is what excites me a lot as a neuroscientist, is the studies on other areas, which I'm going to give you a glimpse of. So the difference between the two is the coil. So this is the figure 8 coil that I just showed you. This is the H1 coil. So the depth of penetration, and because of the complexity of some illnesses like OCD, autism spectrum, etc., we need to target other areas than just this area of the brain, which is helpful for depression, but we can go in other areas. So I'm going to show you a little bit on how that works. This is our old office.
I'm 24. I just graduated from UC Berkeley. It didn't really hit me having depression until I was around 16, and it didn't get severe until I was 18. And it kind of triggered by like traumatic events and things like that, and it did affect my life. I mean, this is when I was in college, so as much as I went to such a great school and all these things, it would affect my studies. I went through therapy kind of my whole life, and I've tried.
So as I have 15 minutes, I'm going to move on. Remember, I take pride being a good time manager. So bear with me. By the way, a lot of these are on our website. Go to the media section on the website. Okay, so basically this is a 2-second stimulation, 18 hertz, 20-second pause. The whole treatment is 20 minutes. And it's done 5 times a week for 4 weeks. And then if necessary, we can do twice a week for up to 3 months. So this is the exciting slide. So both devices are approved for depression. But if you look at autism, so the asterisk shows you some European countries already using it for that. Bipolar, smoking, pain. Actually, we have a pain clinic now in Santa Cruz, and we just got the 3rd generation device. We're going to use it for pain management, Alzheimer's, etc. So basically, the concept of TMS is going to go to other areas of the brain now. How many of you have seen this book, Switched On? Those of you who haven't, please read this book. It's written by John Elder Robison, who is a famous author. He's Asperger's, high-level autism, and you might know the book, Look Me in the Eye. He's the original author, and he wrote the second book. Basically, long story short, the Boston area is famous for more than the Patriots. So Harvard, Dr. Pascal Leon is a friend of mine, head of neuromodulation at Harvard. So he put an ad in the Boston paper on who wants to be in a study for autism spectrum in adults. So John Elder Robison in his 50s was in the study, and the book talks about how his brain switched on, that it opened new areas of empathy, social skills, etc. So it's not a magic, but it opens up new horizons for how the brain functions. So the future is here. So what else is new? So I'm going to show you the 3rd generation device we just literally got, and it's called Neuronavigation. It's like a GPS guided TMS. We're going to start doing that in March. I touched on pharmacogenomics. That's personalized medicine. That's been available for 4 or 5 years. So if any doctor tells you they don't know about it, please research it. It's available. Most insurances cover it. Ketamine infusion therapy. And then this, I bring that back, integrated care. A lot of times it's lack of communication between different providers. Each might be doing the right thing, but if they're not really working as a team, the patient might not be getting it. So neuronavigation, so we have MRI guided. Let me kind of go through this quickly. This is the new coil. It's flexible, it goes to different areas in the brain. So normally, the old-fashioned TMS is you go by measurement-based. Then you can do EEG-based. This is the new device. We do a regular MRI. We load it up in the computer. We have a neuronal navigator software, which I'm going to show you. And then in rare cases, like if you do brain surgery or something, you can do metabolic scan of the brain called functional MRI. So this is the fMRI. So let me go through it quickly. Okay, so this is the new device we're bringing in March. It's called the Neuronal Navigator. I searched and searched and searched and discovered Holland made this device. So I went to Holland and we brought this device. We're going to install it. So basically, this is a GPS-guided device. Patient sits in a chair. If you want to research it, neuronalnavigator.com. And we do real-time MRI TMS treatment with this device. And it's going to open new areas I'm going to show you in a minute. So it's called, the Neurosoft is the company, and it's paired with Brain Science Network. So let me skip through this. So we do a regular MRI, and then we put the patient in the chair like this, and then we localize where their dorsolateral prefrontal cortex is and other areas we want to treat. And then we precision-guided TMS. So this is what you need to look for. Depression, we already talked about plenty. We've been doing that for 10 years with success. So the new device, we can treat psychosis because we can go to the auditory cortex of the brain, temporoparietal area. We can treat tinnitus, which has been very hard to treat. We can start treating OCD, anxiety, ADHD, bipolar, Parkinson, tremor, addiction, autism spectrum. Don't run to sign up for all of these. I'm giving you a preview. If I come back in 2 years, I'll bring data on those conditions because we are on the cutting edge of technology. So we're going to have a lot of these patients to be treated and as appropriate. So let me skip this part. So this shows you the areas. Like, for example, if you're treating psychosis, there's no point of treating the prefrontal area. This is the area we treat, the temporoparietal or Broca's area, because that's where the hallucinations are coming from. So we have precision-guided, and then we know that's the area we want to treat. Tinnitus, there's an area called the Herschel gyrus, which is about this area of the brain. So we can real-time MRI and treat it with the magnet. So then, this is actually more just FYI. They're using it in brain surgery also to localize the areas of the brain if you're removing a tumor or something. This is exciting because now rehab after stroke is going to be guided by this device also. If you have a loved one who develops stroke, we might be able to help with that. So now, briefly, do I have 7 minutes left if I do my time correctly? 7 minutes?
9 minutes.
Oh, perfect. See, I'm ahead of schedule. So let me take a breath here. So what's personalized medicine? I talked about it briefly. So normally when you take yourself to the doctor, they look at patient's experiences, adherence, family history, illness, etc. And that's, I call it the target approach. You know, you throw medication until it hits target. The studies show a lot of patients don't do well, as you've gathered. So let me tell you how pharmacogenomics works. So we have, these are actual patients in the trial. So venlafaxine XR, which is an antidepressant. So this young man is on 75 milligrams, no side effects, doing great in the trial. This gentleman is on 150, so double the dose, no benefits, and he has tons of side effects. This young lady is on 300 milligrams, no benefits, no side effects. Why are they different? Because of their genes, right? All right, so let me show you. Pharmacogenomics is defined as information about a person's genetic makeup or genome to choose drug and drug doses that are likely to be effective. National Institute of Health, National Human Genome Research Institute. So we have a new layer now. So if somebody's tried 1 or 2 medication, please don't try 3 and 4 or 5 without getting some guided decision making here. So this is very quickly show you that 56% of patients, green, so the color-coded report comes in green, means you got 2 normal genes. Let's say somebody's on Zoloft. If Zoloft comes in the green, it means you have 2 normal genes from both parents for that medication. Yellow means they have 1 normal, 1 abnormal gene, which might still work, but they might have inconsistency or maybe more side effects. Red you should try to avoid. It means it goes through very quickly or very slowly, and that might be not the right medication. So hold your questions, but it will give you, and we give a copy to the patient to take home with them, because the genes don't change. This becomes a permanent thing with other doctors also. So the 3 patients basically are, again, this guy is the pharmaceutical company's dream. He did well on the minimum dose, right? So this guy, unfortunately, was a poor metabolizer. He should not be on the venlafaxine. He should be on something else. This lady was an ultra-rapid metabolizer. It acted as a sugar pill washed through her body. So ketamine infusion. So ketamine is used for pain management, anesthesia. It has been a drug of abuse. We've actually, the only reason I got into that is one of my doctors was trained at Emory, and she was running the ketamine program there in research and has a lot of experience. So we started doing it a couple of years ago, and we've had some great successes. So now I have good news for you. I still have 5 minutes, and I'm here for any questions you have. Thank you so much for your attention. By the way, these are the websites, our two, and then the companies that sponsor the devices we have. And thank you for your attention. So questions?